All right, so my name is David Peters. I'm a fifth-year neurosurgery resident, and today I'm going to be talking about management of thoracolumbar fractures. So thoracolumbar fractures are super common. About 90% of all spine fractures. I think every night on call we see 2, 3, 4 of them. Big reason for that is you have the transition zone between the rigid thoracic spine and to the mobile lumbar spine, and you get increased stress at this level, which leads to more fractures, more ligamentous injury. These fractures are, a heterogeneous group that's often lumped together, and that can make data more difficult to interpret. You have a lot of confounding factors, and there's a lot of debate over the management. Probably the biggest confounding factor is the inter-rater variability and difficulty in consistently classifying different fractures. So there's been a lot of different systems that have been invented to try to classify these fractures, and also people love to publish these classification systems. So starting at the top, we have these common terms: burst, compression, chance, stable, unstable, that are terms that we commonly use to describe them, but it's often used inconsistently by different people. And even within these terms, there's just a lot of variability. So one of the first classification systems to kind of address this was the 3-column model of Dennis, which was proposed in 1983. And so he broke the spinal column into an anterior, middle, and posterior column. Anterior is the first half of the pubic body. The middle was the second half and first part of the pedicle, and then the posterior column was posterior elements. And he argued that a fracture was unstable if there was 2 consecutive columns that were fractured. So the anterior and middle, or the middle and posterior, or all 3. So this was a start, but it had kind of still had a low reliability and lack of consensus among people defining the morphology. So in 2005, the Telex, which is the thoracolumbar injury classification and severity score, was published, and this is probably the most common classification system that's used today. So the good thing about this system is that it classifies the fractures, and it also helps guide management decisions. So that's a positive. Again, though, it has similar problems in that the reliability and the inter-rater reliability of the ability to properly put the fracture into one of these categories is not great. And then you also have the suspected integrity of the posterior ligamentous complex. And so you take your fracture and you assign it points based on the morphology, the posterior ligamentous complex, and the neurologic status. You come up with a point total. If it's greater than 4, surgery is recommended. If it's 3 or less, they typically recommend non-surgical, and then a 4 is kind of a dealer's choice. This doesn't take into this system. The major criticism of this system is that it doesn't take into account deformity. So you can have a burst fracture that has 30 degrees of kyphosis, and that would have the same 2 score as a burst fracture with 0 degrees of kyphosis. And then also doesn't take into consideration pain. So a lot of times patients have burst fracture that looks stable, but they can't walk and they're bedbound for weeks. So the biggest one of this is exclusion of relevant clinical information. And then the next system this one came about in 2013. This is the other one that's commonly seen in the literature. So this is the AO spine classification system. So the good thing about this is it does have a good inter and intra-rater reliability. It's a lot easier to specifically label a fracture with this system than the other 2. But it doesn't have the same management guidelines that the Telex has. So your A-type fractures are compression, axial load fractures. Your B-type fractures are more distraction, flexion extension injuries. And then type C are the translational injuries. And so the downside of this is it's not super easy to use. And, it's sometimes can be hard to remember, the difference between a A1 and an A3, or a B2 and a B1. So that is its major criticism there. So 2 fractures, the one on the left, obviously unstable neurologic injury. This would be a type C fracture. I think pretty much everyone would agree that needs surgery. The one on the right, technically a A3 fracture. It's a burst fracture with maybe a small amount of kyphosis. These are the ones that are hotly debated. And these are kind of what I want to focus a little bit more on. So as I was saying, you have your clearly unstable fractures that have a neurologic deficit, fracture dislocation, gross malalignment, severe deformity. Those are the ones that everybody agrees need surgery. Then you have your clearly stable ones where they have good alignment, they're able to ambulate, they have some pain, but it doesn't severely limit them, and no significant deformity. Everyone would agree that you shouldn't treat those with surgery. And then you have this potentially unstable, it's kind of a gray area, where they don't have any neurologic deficits, but they may have, significant canal compromise. They may have a kyphotic deformity. They may be completely, they may be bedbound by pain. And so upright imaging is a good tool here because it can help define what's happening as they ambulate and define better the deformity. And a term that I like for these fractures is delayed instability, because a lot of times these patients will be able to do some, they'll be able to walk some or sit some and bear some weight with an acceptable amount of pain. But as it goes further down the road, that deformity worsens or that pain increases and the vertebral body collapses, and then down the road they get into problems. So that's something to consider about this gray area. So for these gray area fractures, there is a significant amount of debate on what we should do with them. It's often difficult to interpret the data, and it sometimes conflicts. And I think that the Congress of Neurological Surgeons tried to come up with guidelines in 2019 about how to manage these fractures, and they even said there's insufficient evidence. They basically said that you need to just decide on your own at your best discretion for deciding of operative versus non-operative management for these fractures. So I'm gonna try to come up with a couple principles here to help guide us our discretion. And the first group of people that you have are the minimalists who don't think any of these fractures need surgery. So they would say no surgery unless there's neurologic deficit or very gross, obvious malalignment, and they recommend treatment of these fractures with pain control rest and plus or minus a brace. And the benefits of this obviously is that you don't have the surgical risk and you don't have the cost of surgery, which is a significant benefit. And there are some data that shows that the long-term outcomes, in 3 and 4 years down the road, are similar between operative and non-operative management for these fractures. The cons are that while these patients heal, they can often heal with a deformity. And particularly younger patients may be able to compensate for that with that deformity after it heals, but that can create further problems down the road as they get older when they're no longer able to compensate. And as we know, the increasing importance of parameters of the spine and deformity, that may be something that is going to lead to further problems down the road. And then the other thing is, a lot of times non-operative management means somebody is unable to work and lying around in bed for weeks. And so with surgical management, you get a quicker pain relief, quicker ability to ambulate, and you return to work quicker. And then the other thing is, some people promote bracing, but there really is no strong evidence that shows that bracing does any benefit over non-bracing if you're going to treat them non-operatively. I think it makes us as surgeons feel better if we're putting a brace on it, but there's no evidence that shows that it actually has a significant benefit. So then on the other side of the spectrum, you have the maximalists, the people that promote aggressive and early surgery. And this is traditionally with an open approach and pedicle screw stabilization and then arthrodesis across the fracture site. And so the proposed benefits of this are you have an earlier return to work, you heal faster, you ambulate sooner, the fracture gets reduced, and you have good alignment and you correct the deformity. Cons, if you arthrodese across several levels of the spine, you lose that segmental mobility of the spine, and which then can create further problems down the road. But and then there's also obviously the significant risk and cost of surgery. And then, as I mentioned before, I would call it more intermediate term, 3-4 year outcomes that we do have suggest similar benefits for non-operative management. As a side note to that, there is some newer evidence that's showing that fusion might be overrated for these burst fractures. And as an alternative, you can stabilize the fracture, allow it to heal, and then potentially remove the hardware. And the benefit of that is that you retain that segmental mobility of the spine once the fracture heals. So this was a really good systematic review that I found that looked at, there was 5 randomized controlled trials that compared open reduction with fusion to open reduction fixation without fusion. And they had 220 patients and an average follow-up of 69 months. And what they found is that the group in which arthrodesis was used, it did not have any significant difference in the clinical outcome compared to the people that had just stabilization. And then arthrodesis was also associated with increased surgical time, increased bleeding, and it didn't improve the radiological parameters. So it might be overrated for people that have fractures. Now, I would say if it's just a ligamentous injury, then arthrodesis is likely not overrated. You can't, stabilization alone is not going to heal a ligamentous, it's unlikely to heal a ligamentous only injury, as there's nothing to really heal there. So in light of this data, I think that there is a potential middle ground that is in between the minimalist and the maximalist that might be the best option for these fractures. And so that's percutaneous stabilization. And what you can see here is that with percutaneous stabilization, you preserve these paraspinal muscles largely. Your open approach, you're spreading those, and there's a lot of tissue damage, atrophy of the muscles, and you lose a lot of stability of the spine when you're taking away all those muscles. So a minimally invasive percutaneous approach preserves that musculature, which is less pain, less bleeding, less risk of infection, and better stability. And the studies that have been done so far that have looked at percutaneous fixation for these fractures show the same, early benefit in return to work, ambulating sooner, correcting the deformity, and they have less dissection and less infection, less complications than the open traditional approach. So the con that is often proposed for this is that when you place that hardware in there, you're often going to have to do a second surgery to remove the hardware about 6 months to a year later when that fracture has healed. Otherwise, you risk, that hardware moving around as the patient's moving around. It's not fused across it, so that can create pain and potential problems. Is what the fear is. And then you still, compared to non-operative management, you still have the cost and risk of surgery, and then there's not a lot of long-term data on this type of approach for these fractures yet. So this was a paper that I found that I thought made a good effort to compare. It's the only paper I found that I thought made a good effort to compare non-operative management to the traditional open with surgery to the minimally invasive percutaneous stabilization. So they had 78 patients. These were young, mostly healthy patients that only had one isolated thoracolumbar fracture and no other traumatic injuries. So they're neurologically intact, and it was a burst fracture with at least 20 degrees of kyphosis, and only in one level fracture between T12 and L2. So they were very selective about the patients that they included in this. They discussed the options with patients, and they let the patients choose what they wanted to do. 30 elected for conservative. When they started this prospective data collection, they were doing open surgery. So the first 23 got open surgery without fusion. And then the second half, 25 got the minimally invasive. And all of the people that got surgery were fixed with 2 above and 2 below the fracture. There's no screws in the fracture level. And so for the people, the open surgery, they elected not to arthrodese them. So for all people that got surgery, their hardware was electively removed at 6 months to a year post-op. And when they analyzed all this data at a year and 18 months, and then 6 months after removal of the hardware, they found that there was less time in the hospital for minimally invasive. They had better ODI scores for the minimally invasive, and then no difference in the correction of kyphosis between the minimally invasive and open group, but both were better than the conservative group. And then there was 5 patients in the conservative group that had progression of their fracture and ultimately needed surgery. And then there was only 1 in wound infection, which is in the open group, and no complications in the minimally invasive group. So I think this is the best article I could find kind of illustrating this. But, so we looked at some of our data. We've been doing perc screws for thoracolumbar fractures as far back as 2008, and it has become progressively more popular among our surgeons. And so the first group that we looked at were patients that this was treated between 2008 and 2016, and there was 93 that we found that were treated with percutaneous stabilization. They were primarily treated with a short segment, so 3 or 4 levels, and that was only used if screws could be placed into the fracture level. If we couldn't get a screw into the fracture level because of, then we would use 5 or more levels. And then there was one surgeon in the group whose practice was to electively remove the hardware at 6 months to 1 year, versus most of the other surgeons basically said, we're not going to electively remove it unless it causes a problem for you. And so what we found out of this group of 93, age was 44, BMI was pretty normal, these trauma patients. And then you can look at the AO classification of the fractures. And then for the revision surgery needed, there were 16 that had their hardware removed, 3 where the construct failed and they needed an open surgery revision out of 93, and then 2 were infected. And then our follow-up, 19 were lost to follow-up, 19, which is pretty common, I think, in trauma cohorts, and they didn't make follow-up at 3 months. And then 74 had 3 or more month follow-up, and average was 16 months. And so just another slide on the data, only 2% infection rate, 80% had at least 80% followed up at least 3 months, and average was 16 months. So I feel like this demonstrated durable long-term results with a very low complication rate for thoracolumbar fractures that did not require decompression. So these were percutaneously fixed. There was no decompression. And then the prophylactic removal, which is kind of a side topic, but that may or may not be necessary. It's a quick surgery that can be done in the outpatient procedure, and you take it out and you regain that segmental mobility. But if a patient is doing fine and they don't want that, if it's a smaller construct, it's probably not a lot of, we haven't seen harm of leaving it in. As you can see, we have a lot of patients that never had it removed. So in conclusion, summarizing all this that we have, and I admit that this is a debated topic and there's strong opinions both ways on this, but for the potentially unstable fractures, this gray area that I'm talking about, I think the most important thing is just thoroughly discussing with the patient and figuring out what they want to do and what they're comfortable with. As I said before, the benefits are likely it's going to help them walk better. It's going to prevent them from developing a deformity down the road, which may potentially need a bigger surgery. It may increase their chances of returning to work sooner. But then you have, again, the risk of surgery and the cost of surgery. We've shown with the perc screws that the risk of surgery is pretty low, but it's definitely higher than, it could be higher than the non-operative approach. But usually there's little harm in recommending a trial of non-operative management with close follow-up. You can let them say, we're going to let you try to walk. If you're unable to walk, or this pain is just severe, getting worse, or we get uprights and you're developing a deformity, then we can do surgery then. And so like I have also mentioned before, the non-operative management has similar long-term reported outcomes to surgical management. That's the 3 to 4 to 5 year range. The outcome has been largely similar to surgical. That's comparing to, almost all of those are comparing to an open approach with arthrodesis. And then the other thing about the non-operative management is that braces have no proven benefit. So that's another thing to consider with that. Now, as I've discussed, the benefits of operative management: better pain control, quicker to mobilize, better alignment. Arthrodesis, if you are going to stabilize these patients, arthrodesis might be overrated if there's a fracture. If it's a purely ligamentous injury, you're going to need arthrodesis. And then for the reasons I've discussed, percutaneous may have the same benefits as open with less of the complications, and it's easy to remove if you need to. But those are my references, and I'll take any questions.
One thing I would say is, I know in the paper that you talked about, I know they use the term conservative, but the opposite, the antonym of conservative, right? conservative, non-surgical, conservative, typically in the line of conservative radical. Paper that we talked about how surgery restricted their options, so it's not really a radical option. So even though they refer to it as not as conservative, I think that surgeons that's interested in refer to non-surgical. Having said that, there's certain instances where surgery is certainly a conservative option. That's fracture dislocation put up to say that that's conservative. That I think that's insane to put that in brace. So words matter, especially in this day and age. Everyone's making an effort to get away from this concept that non-surgical is somehow conservative. Non-surgical can be radical. Something that fracture dislocation in brace that would be a radical alternative, not a conservative. And so the words matter, and so I'll just say that. I know that they need the authors, that's what I use it. Having said that, our experience has been exactly as you described. I think we did a good job of capturing this middle ground. This is the tough population, right? This is the population that's not compliant with braces. You mentioned that there's not a lot of evidence for efficacy of braces anyway. The loss of follow-up, never mind, come to the doctor's office, never mind actually what the doctor tells them to do. So getting instantaneous fixation, allowing them to mobilize in short and possible stay with a low rate of infection. That's one of the problems with the open treatment folks, because a lot of them have multiple comorbidities and are playing on a large wound, large open space. And so it's been, before we started doing it, basically, population probably 20% infection rate. So it's remarkable to that particular population. I think it does always represent that middle ground that you're talking about. And then you mentioned again that they continue to be on the non-surgical conservative option. Say that somebody is going to be around 4 years later to have the same outcome as somebody who's mobilized. Say that that's conservative doesn't sound right. And so again, I think that a lot of these patients, fracture patients in general, don't fall into other people's idea that non-surgical management is radical and non-surgical.
Two questions for you. One, when I agree that I really like this technique for these fractures, it's a great option for people. One of the things when people were first doing it, they were a lot talking about taking the hardware out, and I haven't taken the hardware out unless it was loose or some other particular issue. The question is, if people who do take it out, I assume from your literature, do they do an open removal of the hardware? Because that's always, it seems like you're trying to go percutaneously to take all this stuff up is just mucking around in the paraspinal TA. You don't divide it off the midline, but so you sort of lose that advantage. What is the practice that you mostly read about? Is it open removal of all hardware?
No, just reopening the same incisions, and yeah, you can reopen the same incisions and take out all the hardware, and you still have you go through the paraspinal a little bit, but it's still significantly better than spreading everything.
Second question I have for you is, what about the patient with this fracture who there's some indication for decompression? You're doing any sort of hybrid percutaneous open laminectomy in conjunction with this, or if they need a true decompression, or is it an open procedure? Your algorithm.
It is possible to do a decompression with the minimally invasive approach where you put down a tube and shave off a bone, but that becomes, typically if somebody has a big spinal cord injury or compression, you need a very big decompression, and putting a tube down and doing that at every level, that gets, that seems like you're trying to prove a point kind of more than just doing the obvious thing, which would be to open up and take off that. If you're going to go down there and take off all that bone, decompress them, then you're losing a lot of that stability that you preserve with a minimally invasive approach. So I think that's kind of counterproductive to try to go down and put a tube. It's possible, and it kind of depends on the situation, but the easier thing would just be to do it open. Yeah.
And lastly, in your series, did you guys look at deformity correction with percutaneous approach? Because I think that's one thing that you theoretically can do percutaneously, but it's not quite as powerful
We have not done that yet. We're still going through the data, and we have actually all the perc fractures from 2016, 2020 as well. That's like another actually 200. So I think that would be a good thing to measure, and it would make the data a lot stronger, and you have a more, more hard fact point to argue your point with. So I think that would be good.
David, thanks for a great talk.
Mhm.
And I want to ask you a subset question. We're going to do radical treatment and treat somebody in a brace. These things are expensive.
The brace?
They're really expensive braces.
Yeah.
Now, I know from our literature in my world of sports that, if you look at corticosteroid treatment for a long term, it doesn't work. Jet Coon, for some reason, is following people 2 years after a corticosteroid injection, wondering why it doesn't work. We all know it works really well short term. It's a means to an end in my practice. What about a brace for like short-term stability and pain management for a patient that otherwise would be in bed? Is there any role for that? I mean, does the brace have any short-term? We obviously know long-term it's not going to answer the question.
So, there's nothing that you can say that's published that proves that point, but I think in our experience, we definitely see people that are hurting, and then you say you can wear this brace, it might help you, walk a little better without pain. They put the brace on and they're able to get out of bed. So I think there are anecdotally, I can think of some times where it helped the person with their pain and get out of bed sooner, but overall I think it'd be hard to prove that. And I don't think there has been anything published on that.
So there's no study showing the brace works at all?
Not really. No, I mean, nothing that, not really, I would say.
Well, they're really expensive.
I know. Yeah.
I agree with you, and most of the data there kind of looks at deformity prevention and braces. And I agree with you that braces do not sort of work. If it's treatable non-operative, it's treatable non-operative without a brace. What I talk to people about is it does provide some level of pain control and some level of slowing them down. When you have a big clamshell on, you're not going to move as much and do as much, just as a general decreased activity. But yeah, I mean, look at the data. People still put folks in TLSOs for L4 and L5 fractures. There's zero data that there's any functional bracing at the L4 and L5 level for TLSO. Basically worthless. If you want to brace that low, you have to put a thigh extension on them, maybe give them some help.
Same thing I offer. You can hold the shoulder, you can do so many extensions. And on top of that, they're really costly when they measure general for bracing. And like he mentioned, they are expensive to get 50 braces. It's typically somewhere around several $1,000. And to your point, it does slow the patient down, but that necessarily a good thing. And most patients are going to have broken back. Rolling the brace, it's hard to strap in and off the class, et cetera. And so the idea is that you want to mobilize patients sooner and faster, and a brace really doesn't do that.
You can't just talk about if it is a one or a three or whatever fracture. That's an injury to a person. At the time, has to look at it. You can't talk about putting a brace on somebody that's got a 44 and and move this long fracture, you mobilize it from femur so that you can get the patient up and move. But you have to take all of these. We did this, we talked about bracing forward, putting somebody in the femur, and it all of this equipment brace and expect nurses to get them up, try and mobilize them, all this other stuff. Braces actually make the situation worse. You have to do it in the context of where does that fracture sit. Long bones, multiple injuries, long bellies, all of that. They need to mobilize them. Okay, and brace to the waist. And non-operative become radical, where operative becomes quick. Things you can mobilize. You have to look at context for each one.
Okay, well, thank you, great talk, good discussion, very, very germane to all the orthopedic and our surgery residents. These are highly tested topics on all of our tests we take. So thanks for providing high yield possibilities for us. Thanks, everybody.
Thank you.